Good evening, good evening.
Conducting and coordinating these important scientific meets. Dr. Mekle, a very dynamic doctor and MPIP secretary. Dr. Ashish Pathak, my dear friend and president of Ujjain IIP, and he's very humble when he says that Ujjain is a small branch. Ujjain is a large, vibrant branch, I would say, and and Dr. Rajesh Gupta sir and Dr. Rajesh Gupta sir was my immediate senior in MBBS. And it's really heartening to see you all here. And let's start and make keep it an interactive session. And I also welcome Dr. Sumit, who is a very learned pediatric gastroenterologist, and Sufla Saxena ma'am. Uh, Previously, she was at Indore and now is working at in Delhi. And Dr. Kela. So today the topic is basically about acute case presenting like just a minute. ये message ऊपर वाला चलो so fine. So case of viral seemingly viral hepatitis, or rather a case of acute viral hepatitis, and actually not following the normal clinical course and tracking for a more sinister outcome. So acute hepatitis, I would say, not even acute viral hepatitis, but acute hepatitis, which can be of varied course, uh, very typically has these clinical features. Usually, it's the first episode when we see the child, first episode of jaundice. It's a previously healthy child. There's a very typical prodrome which actually we should try and pick up, and it actually signifies that it is most probably viral in etiology. So prodrome is less than 7 days. It consists of a typical viral illness like anorexia, nausea, fever, dark urine, and depending on the degree of cholestasis, the stools may be colic or acolic, and which is followed by an icteric phase. And pretty much like other viral illnesses, the fever subsides with the increase in jaundice. And on clinical examination, there is icterus, hepatomegaly, splenomegaly might or might not be there. And usually there are no signs or symptoms or stigmata suggestive of chronic liver disease. Lab profile, bilirubin usually the bilirubin is less than 5 at the time of presentation, and not usually more than 10 milligram. However, the transaminases in viral hepatitis or drug-induced acute hepatitis is usually usually or rather commonly in thousands. Important point to consider right here is that albumin globulin ratio is not reversed. Sometimes it's very disheartening to see liver function tests without the mention of total proteins and serum albumin. So we should try and insist for a LFT to contain total protein and serum albumin, and also see and also have a look at the AG ratio, which gives you a clue. In usual uncomplicated viral hepatitis, it is usually the AG ratio is preserved, and prothrombin time again is also normal. So causes of acute hepatitis in children, I'll come to the case shortly, just one or two odd slides before that. The most common causes of acute hepatitis in tropical countries are waterborne infections like hepatitis A, E, and co-infections. So while I was working as a fellow at AIMS Delhi, a lot of we used to that time it was relatively new doing hepatitis A IgM and E IgM and even ELISAs, and a lot of cases had co-infections of hepatitis A and E. Parenteral infections like hepatitis B and C, and not uncommon are the drug-induced hepatitis. Most common offenders being the anti-tubercular drugs, anti-epileptic drugs, NSAIDs, and few antibiotics, etc. Sometimes chronic liver diseases do mimic acute hepatitis. In fact, general practitioners would see a lot of such cases because then they refer them to pediatric gastroenterologists. Unknown causes or the idiopathic, so to say, usually are inborn errors of metabolism, and now more and more are being labeled courtesy whole exome sequencing and genetic tests being easily available. So the idiopathic part is now dipping, and the specific etiologies are picking up. Reese syndrome, and please always remember that there are a lot of non-hepatotropic viruses which do present with acute hepatitis sometimes. Uh, the common one these days being dengue, then HSV, EBV, CMV, sometimes HIV and parvovirus also present as acute hepatitis. So this is just a review the diagnostic tests in hepatitis. Liver function test, transaminases, bilirubin, alkaline phosphatase, serum proteins, I would say, is very important, and prothrombin time. Acute liver failure, evidence of coagulation abnormality, and any degree of mental alteration with an illness of less than 6 months. Coming to the case which we'll be sharing, which we'll be discussing today. This was a male child born out of non-consanguineous marriage, and he was 10 years when he presented to our hospital. He was referred from Sagar. There was a history of gradually increasing jaundice in 7 days, and why he was referred was because he had become very irritable, and there was a reversal of sleep cycle, plus the behavior of the patient was highly inappropriate. While at the time of admission, on general physical examination, there was deep icterus, pallor was noticed, significant pallor was noticed. On examination, there was hepatosplenomegaly, but the liver was not was just soft to firm, not hard. The margins were normal. No evidence of chronic liver disease or ascites or edema, and there were no features of acute liver failure. On day two of the admission, uh, this there was the icterus was increasing. And the child and the encephalopathy signs and symptoms were also increasing. Like the child started having a lot of screaming episodes, irritable, and so CNS features of hepatic encephalopathy stage 2. He was shifted to the ICU, and mannitol and other measures were started. However, unfortunately, the patient passed into stage 3, became dull, and he was eventually intubated and mechanically ventilated. However, the saturation was not improving. X-ray chest was normal with the ET at carina. Despite this, the saturation was not improving. These are the lab tests. At the time of admission, the serum bilirubin was the total bilirubin was 23, and the conjugated fraction was 15.4. SGPT was in around 4,900. SGOT was 9,700, 9,070. So you can see that the SGOT was pretty much higher than SGPT, which can indicate something. And before we move on to the next slide, I'll ask a question. The albumin was pretty much preserved at the time of admission, and the prothrombin time, however, the prothrombin time was high. Anybody or any expert would like to make some comment here, like
Rakesh sir, there was splenomegaly. You said on examination there was hepatosplenomegaly.
yes,
If
yes, there
you are
was.
having spleen in a patient with ALF, then it may
Pardon,
not be a
pardon. Yeah.
plain. You said there was splenomegaly on examination.
Yeah, it was not huge, but yeah, around 2 to 3 centimeters. Soft spleen was there.
Spleen, so
It was
spleen.
not a big spleen.
But if the spleen is palpable, it is already more than twice this normal size to become
Yes, yes, yes.
palpable. So if you have a palpable spleen in a child who is presenting like ALF, then the possibility of underlying CLD becomes high. So
True.
we should have kept the possibility of acute and chronic liver failure when we palpated spleen in this patient. Then the
Yeah,
lab
we did.
report.
We did. We did.
Okay, sir.
So actually, I will go stepwise just because we have pediatricians with us. So initially, as you said, Dr. Rakesh, that the child is pallor, hepatosplenomegaly, and irritability, hepatic encephalopathy. So my initial impression was there could be some kind of hemoglobinopathy, because it's presenting with pallor. But looking at the blood picture,
Excuse
we
me, I
need to
would
know.
differ here. If the child has high colored urine, then I will not keep hemoglobinopathy as the differential. The simple way to differentiate between a hemoglobinopathy means hemolytic jaundice versus liver disease jaundice would be the urine color. The child has deep icterus, yellow urine, then hemoglobinopathy almost goes out of the picture.
Fine. So thank you so much, Dr. Sumit and Dr. Sufla. The point which I wanted to emphasize here was that SGOT was almost double the SGPT, uh, which does suggest uh, uh, some sort of non-hepatic cause in addition to the hepatic cause of this increasing jaundice. So we'll come back to that, because usually in hepatotropic viruses the SGPT, the ALT is higher as compared to the AST usually. So however, uh, around 2 days later, while the child got intubated, the bilirubin shot up to total of 38.7, and the major fraction was conjugated. The SGPT started decreasing. The SGOT started decreasing. Albumin also started dropping, and the prothrombin term improved relatively. So, Dr. Sumit, would you like to make a comment on this increase for general
Yes, sir.
pediatricians and PG
So,
students who are with us?
yeah, absolutely. So we have a palpable spleen with very high bilirubin and high SGOT than SGPT. So there could be a non-hepatic source of bilirubin also in this patient. In view of palpable spleen, SGOT more than SGPT, and bilirubin going to the tune of 51. So usually the bilirubin, because of only hepatitis, does not go beyond 20, 25 or 30. If you have a bilirubin of total more than that, then there is either associated hemolysis or renal failure that is
Great.
causing so much high bilirubin. So,
Absolutely. And the rising bilirubin and the falling SGOT-PT also points towards a failing liver.
and simultaneously, if we could get a hemoglobin values also, so that would have been.
Yeah, sure. I'm coming to that. So, Khair, by around the fourth or fifth day of the admission, the bilirubin was at all-time high of 55. This is probably the highest bilirubin which I have seen in such uh, age group. And the conjugated bilirubin was 40. And the SGOT-PT were ever decreasing. They had come down below 1,000, both of them. The albumin again had dropped to 2.6. Prothrombin time was not that much deranged.
गाना कोई बच्चे सीरियसली नहीं लेते हैं मुझे क्या
Can
What
you
is it?
please mute the mic?
Left profile. प्लेन हेपेटाइटिस का केस ये सब हो गया
55
Excuse
हो
me.
गया
हाँ 55 हो गया
खालसा मैम प्लीज म्यूट कर लें आप अपना
सॉरी
मोबाइल।
सॉरी
डॉक्टर राकेश प्लीज
Coming to
कंटिन्यू।
the hemogram, as Dr. Sumit was saying, at the time of admission, you can see the hemoglobin was around 9.1, platelets were 1.2, the RFT was relatively fine. The serum sodium was 141, and the ABG was also looking good, but gradually the hemoglobin dropped to 5.6. The platelets had dropped to 45,000. The RFT got pretty much deranged, and the child developed hyponatremia and significant acidosis. So, Dr. Sumit and Sufla, any comments on these, and what are we heading towards? Any assumptions on diagnosis so that we can actually come to the diagnostic test and then discuss?
This child ever had fever, history of fever?
Not much.
Right, because with the falling platelet, hemoglobin, so there's, as Sumit rightly pointed, that there is hemolysis, there's rising
There are
creatinine
evidences.
with renal failure
Absolutely.
with metabolic acidosis.
Yeah.
There is some sort of hemolysis going on that is causing the fall in HB along with the rise in the serum bilirubin, and that severe hemolysis is also causing the renal shutdown, because if it is not hydrated properly, severe intravascular hemolysis can lead to the renal failure, and that is another contributing factor for the so much rise in the bilirubin.
So I am
Right.
thinking about other differential, virus disease, dengue, leptospira, something like that.
Great.
And along with that, I would keep the possibility of Wilson disease here, in the of
Okay.
hemolysis, palpable spleen, and apart from what ma'am mentioned, I would add this DD also.
Great. At this juncture, before we go on to before I reveal all the diagnostic tests, any participant or the seniors would like to just suggest some sort of a diagnosis before we unveil the diagnosis? I'm almost there.
So, Rakesh bhai, if I was in Mumbai, I would think definitely of leptospirosis. This classically fits into that. Renal failure, liver failure, hepatosplenomegaly, and fever is absent, but that could be one of the thing. And other thing would be
Hemolysis is not usually not a very
Exactly.
prominent
Hemolysis is
feature.
not the feature of leptospirosis.
Yeah. However,
and dengue.
Dr. Ashish, yeah, great.
And dengue. Second thing would be dengue, and third Wilson's, obviously, because of three things different.
Dengue again would lead to rise in hemoglobin with hemo concentration. So please, don't get misguided by the platelet. There's a huge, significant hemolysis which was happening. Platelets could be down because of the viral etiology. And as Sumit was suggesting that acid hematin was getting deposited in the renal tubules, which was leading to this acute kidney injury, or ATN rather, AKI to ATN. And hyponatremia was because of the SIADH, despite the fact that we were using hypertonic saline as well. And so let's come to the diagnostic tests.
Another thing, sir, we have is this is a sickle cell belt, hemolytic belt MP. So
Yeah.
we have seen cases acute viral hepatitis. They are coming for the first time along with the evidence of hemolysis because of underlying hemolytic anemia. The child might be having underlying complex hemoglobinopathy not identified so far, and he has acute viral hepatitis, and that is become evident down the line. This may also be a differential.
Yeah, great. Absolutely fine. I agree on that. So, because the patient was sick, intubated, there was stage 3, 4 encephalopathy. We did counsel the parents to airlift the patient to a center equipped with liver transplant. Last chance for all the participants to suggest some very important test which should be done ideally. I would say not in all uncomplicated hepatitis, but you would agree after this case that it actually changed my practice. Anybody? Not about typical CLD workup or something, but a very common test which ideally should be done when there is inappropriate rise in bilirubin and the
Peripheral
commonest
smear.
cause of
Peripheral
pardon?
smear. Peripheral
Yeah,
smear.
peripheral smear definitely, but then that won't clean the diagnosis. That would just tell you that there's hemolysis, intravascular hemolysis. So
Retic and
let
LDH.
There are some answers in the chat box also, so you can check the chat box also. There are good answers in the chat box also.
I'll check it later. Let me
No,
do it.
no. About this question, what you asked is there are answers.
People have written serum
Okay, chat box. Let me open the chat box.
Yeah.
Fine.
G6PD has been written there.
So serum ceruloplasmin, KF rings, and ferritin. G6PD, Dr. Prince Agrawal is pretty much close, I would say. And Dr. Dilip Gupta has also suggested HLH, which is pretty much plausible, I would say. So Prince gets the prize. a big chocolate, Sumit would hand over.
Surely, sir.
So, hi, Prince. So, coming back to this case, the viral serology, the child was hepatitis A IgM positive. The autoimmune panel which we had sent turned out to be negative. The serum total immunoglobulins were also within normal limits. Serum ceruloplasmin we did was normal. And the only saving point was that we did do with one of us did a G6PD before the blood transfusion. The HB electrophoresis also turned out to be normal, which was a pre-blood transfusion sample which we drew. Sometimes what happens is in a sick patient with a dropping HB getting intubated, the intensivist or the doctor on duty might just give Paxils without uh, worrying to do a G6PD or a electrophoresis, and then it's very difficult to make out the diagnosis. So the saving point was that we did a G6PD and it was grossly deficient.
Can
The
I ask
baby
a
was
question, Rakesh?
not, yeah.
Is it possible to have splenomegaly in intravascular hemolysis like G6PD?
With overriding hepatitis A, yes, it can be. It was a small, like soft 2 to 3 centimeters spleen.
Okay, so 2 to 3 centimeter only. Okay.
Yeah,
Sir,
yeah,
in
yeah.
the
That is not a massive splenomegaly. It
Okay.
was just palpable, so to say, and
Okay.
it could be a part of a viral hepatitis as such.
Okay.
sir, excuse me. Sir, we should have done a retic and LDH also initially because even HUS can come like this.
Yeah, so retic count was high, and
Okay.
LDH was also high.
Okay. Okay. So G6PD closely mimics HUS many a times.
Actually, I agree. I agree on that. So true. And so that this child was we ventilated for 5 days. Fortunately, after multiple transfusions, almost eight. The child required 8 transfusions as the hemolysis was absolutely unabated, and plasma also we had given. And by God's grace, gradually start the parents were not interested or rather non-affording for airlifting the child, so we had to continue with all our ALF protocol, and we could discharge this child after there is a bit of a around 2 weeks of stay in our hospital. So just 2 3 slides and then I'll conclude. The pulse in acute liver failure management is basically the measures to reduce cerebral edema and managing coagulopathy, maintaining homeostasis with appropriate management of serum electrolytes and blood gases with ventilation are the mainstay for treating acute liver failure in the absence of liver transplantation or till we can arrange for a transplant or the patient improves. Prognosis of stage 3 and 4 hepatic encephalopathy, as all of you would agree, is extremely guarded in the absence of facilities for liver transplantation. The final diagnosis, the discharging diagnosis for this patient was acute viral hepatitis A positive, G6PD deficient, fulminant hepatic failure, hepatic encephalopathy, stage 4 respiratory failure, and acute kidney injury. In fact, this I have probably omitted, but this child also had pancreatitis in between. The amylase life is short up and then gradually they settle down. So that was probably a part of the viral hepatitis only. The last point is important that despite increasing levels of bilirubin and decreasing SGPT, prothrombin time INR values were not that bad. So we had this at the back of our mind that probably the liver is not that bad as the LFT is showing it to be. Coming to the management of acute hepatitis, it's actually non-specific, supportive, and symptomatic. Intravenous rehydration in persistent vomiting is indicated. No role of bed. This is about uncomplicated acute viral hepatitis. No role of bed rest and dietary restrictions in cases without evidence of ALF. Absolutely no role of antibiotics. However, in this case, because he was already in stage 2, 3, we were giving broad spectrum antibiotics along with antifungals. No role of antibiotics, herbal liver tonics, sorbitol, or steroids in acute viral hepatitis, uncomplicated viral hepatitis. And as Dr. Sumit was trying to indicate, when should we suspect a chronic liver disease? Usually in cases even presenting with mimicking or acute hepatitis, children who already have a chronic liver disease, the liver is usually a bit shrunken, not very much palpable, and is pretty much hard. People who are doing it would immediately pick up that this seems to be a chronic liver disease with sharp margins. Spleen is usually more than 3 centimeters palpable below costal margin, and sometimes it's huge rather. Prominent abdominal veins. Important is AG ratio reversal at contact. AG ratio reversal again can be a true one, wherein the albumin is not low and there is a hypergammaglobulinemia. And another one is when the albumin is very low and the globulin is normal. This and you can actually appreciate it's like a AG ratio reversal. So the other one, when the albumin is not very low and there is a hypergammaglobulinemia, is a very typical feature of autoimmune hepatitis and other chronic liver diseases. Past history of liver disease, history of hepatitis B in family, stigmata of chronic liver failure like clubbing and other stigmata, history of parental exposure in the recent past, and history of consanguinity. To summarize, respected seniors and dear friends, in complicated acute hepatitis and suspected chronic liver disease, exhaustive workup in parallel saves precious time and cost. Now we even do TMS, GCMS, and sometimes WES to actually counsel the parents regarding the need for transplant and transport. Suppose we pick up some mutations, then we can actually counsel them that we want, and this child absolutely requires a liver transplant. Sometimes these viral hepatitis actually complicate chronic liver diseases, and we can get misguided by this. So the genetic tests do save us in the sense that the parents get convinced. I actually transported a child to Delhi because there were mutations in WES. Efforts should be made to identify cost-effective means of establishing diagnosis and those which are minimally invasive. Thorough history and clinical examination are the cornerstone in the diagnosis of hepatitis. Investigations are considered to establish the presence of hepatic involvement, its severity to establish causal relationship and assist in the management and prognostication of the illness. And in acute liver failure, the primary task is to provide optimal supportive care and then establish etiology. As I was saying, because etiology is very, very important as far as prognosis and the outcome is concerned. Thank you. This is the last slide. And coming back to the topic, so seemingly simple case of acute viral hepatitis going on to have a sinister course can even be a case of acute viral hepatitis with ALF, with underlying hemolytic diseases, or CLD masquerading as AVH or AVH complicating a CLD. So please try to find out the cause as much possible in most of the cases, which will save us and the patient as well. So I would like to thank you all for contributing to the talk and listening me patiently. Thank you so much.
Thank you, Dr. Rakesh. You have very well highlighted the conditions which may mimic the viral hepatitis, but actually there may be some other etiology. And you have very well highlighted one more thing which I also learned, that SGOT, if it is high enough, then we should think of the non-hepatic causes. So this is very useful tip for all the audience. Some questions are there in chat box, and I'm trying to ask.
Now we can allow, sir.
Yeah, questions are from the chat box. I am reading, sir. You have Dr. Rakesh asked that what is subacute or chronic course of acute viral hepatitis? Dr. Rakesh or any expert can answer.
Pardon, sir?
What is subacute or chronic course of acute viral hepatitis?
Dr. Rakesh, you will see the chat box. You will open the chat box and see that.
Yes, so in chat box, Rawat sir asked, initially the first question was, what is the classical course of acute viral hepatitis and what stage should we start worrying? So this is very much pertaining to the topic of the day. So classical acute viral hepatitis starts with the prodrome, which may last from 3 to 5 days. It starts with abdominal pain, anorexia. Anorexia is the most prominent symptom. It may be associated with vomiting, fever, abdominal pain, and then it is followed by the appearance of the jaundice. So by the time jaundice appears, usually the prodromal symptom starts subsiding, especially fever subsides. Remaining anorexia, abdominal pain may take more time to subside. Then this jaundice usually progress in the first 1 to 2 week, and after the end of the second week, jaundice starts decreasing. Liver enzymes usually are highest in the prodromal phase, and with the appearance of the jaundice, the liver enzymes starts decreasing first. Bilirubin decreases later. So in the clinics, when the patient come to us in the ecteric phase, suppose in the first week of the ecteric phase, with the classical history of prodrome, we are suspecting acute viral hepatitis. So we should ask for the feature of early encephalopathy in all patients with acute viral hepatitis, like altered sleep-wake pattern or some irritability, to detect the signs or symptom of liver failure early. And secondly, I would suggest that at least we should do PT and INR once in a case of acute viral hepatitis in OPD also. In OPD, what we usually do, just write bilirubin, SUT, SGPT, that's all. Not even the complete LFT is done in majority of the time, which I see. So at least do a complete LFT along with PT INR once when you have the first encounter with the patient. So that will give so much information whether there is possibility of underlying CLD, if there is reversal of AG ratio, as Mr. Sir said correctly. If the SGOT is more than SGPT, that may be an early indicator of underlying CLD, and at that point we should worry. Whether on examination there is splenomegaly, we should worry. Any other stigmata of CLD, we should worry. Now, if there is family history of sibling death because of liver disease, we should worry. These are the clinical pointers which we should look in all patients with acute viral hepatitis to detect any sinister early. The next question is, can we have ascites in a child with acute viral hepatitis? So ascites is one of the atypical manifestation of acute viral hepatitis. So we had a very good paper published from SGPGI when I was doing my DM. It was one of my DM projects. So we published around 400 patients with acute viral hepatitis, and almost 24-23% had atypical manifestation, and ascites was there in almost around 8 to 9%. So ascites is, although an acute, is an atypical presentation, but whenever you have ascites in viral hepatitis, this is another indicator that there may be a possibility of underlying CLD. So we should not just push it under the carpet. No, this is only viral hepatitis related. At the back of mind, we should think there may be underlying CLD, because ascites in AVH is a retrospective diagnosis once we rule out the CLDs. I think Mishra sir can add on.
Yeah, sure. So, as Dr. Sumit has already very clearly answered based on the guidelines, one question which Sanjeev sir has asked is, what is the sinister INR when we should start worrying? So, to the surprise of most pediatricians, INR can be as high as 5 to 7 before we plan a plasma. So, in isolated INR as high as 5 or 7, which is not very common, should should lead us to transfusion of plasma. However, if the INR is more than 2.5, we should start considering liver failure.
Yes, and that should be post vitamin K.
Yeah. So we should give 3 doses of vitamin K to rule out vitamin K deficiency. And if the INR is not improving and there are other signs, we should start considering the failing liver. What is the role of acetylcysteine? Dr. Rajiv Sanghvi sir has asked. So, sir, I've also answered in the while Sumit was answering, I was typing in the chat box. that NAC has become a standard of care in acute liver failure. And yeah, true. Dr. Dilip Gupta has asked that it is a non-PCM toxicity. Yes, definitely. Irrespective of whether it is PCM or non-PCM, ALF is the standard of care, and most patients and most centers start an N-acetylcysteine pre-transplant in these patients. It's always helpful, and we have definitely personally, despite the fact that we haven't done any study, even at our center, NAC is working well, and most of the guidelines also support the use of N-acetylcysteine in acute liver failure, irrespective of the cause.
Regarding NAC, I would say that definitely for PCM toxicity, it is the drug of choice. But there are trial in non-PCM liver failure also, which have shown benefit in the early hepatic encephalopathy in grade 1 or grade 2, because NAC has other benefit. It is an antioxidant. It stabilizes it is a hepatoprotective, and it also stabilizes the cells in the brain. So it kinds of, apart from the PCM anti-drug, it has other protective roles, and thus it is used, although the level of evidence is not high, but it has been advised that it can be used in early encephalopathy. Duration is up from 48 to 72 hours. Continuing beyond that does not help. So whatever effect has to come will come in first 48 to 72 hours, and this has almost no side effect. So in early hepatic encephalopathy, there is no harm in starting NAC even in children.
Can I ask one
Sir,
question, please? Can I ask one question?
sir, 1 second. Just one last concluding comment on NAC. Uh, there have been uh, expert advises on the fact that it's very difficult to actually make rule out paracetamol toxicity even in cases of seemingly viral hepatitis. So, NAC being a potent antioxidant and having conclusively shown improved survival in adult patients, I believe, Sumit, most of us are actually using NAC even in
Yes,
non-PCM ALFs.
yes, we are using. All centers use it, although the evidence may not be great, but it is a harmless drug, so no, so better to use it.
Pretty much like probiotic use in NEC. Like sometimes but most of us do use.
Yes.
So,
Can I
regarding
ask one?
hypertonic, yeah, sir.
Oh, sorry. So
Sanjay sir.
you please go ahead. I'll ask afterwards.
So just one liner on hypertonic saline versus mannitol in encephalopathy. Hypertonic saline is preferred because most of the cases do have shock, wherein mannitol is contraindicated. Mannitol can even worsen the kidney injury. And the desired there is a desired hypernatremia which we want to induce in cases of acute liver failure. We target serum sodium above 145, wherein hypertonic saline serves both the purpose of reducing intracranial pressure and then induce hypernatremia. So yeah, we should prefer hypertonic saline over mannitol.
Right.
Yeah, Sandeep.
So my question to Dr. Supla, uh, what are the commonest cause, like when you see the patient with a liver failure and you want to go for the liver transplant? So in newborn and in infancy, what are the common causes where you are getting these patients for liver transplant? Dr. Supla is there?
Yeah, so mostly if you think about newborns, PFIC is much more common that I've seen in my practice. Obviously, biliary atresia, if you look at the Indian incidence, it is one of the commonest indication where the child will present with liver failure if the parents have not seeked any appropriate, timely medical advice from their pediatrician. So then that's the time when they present a liver failure infancy, and then they immediately need a liver transplant. So before commenting on the second part, Dr. Rakesh, very nice presentation. I've seen a lot of G6PD deficient cases, but this is the first time I've seen that a G6PD deficient, a 10-year of age, presenting directly in hepatic encephalopathy. That's quite a rare finding because this child must have been G6PD deficient from early on, And I'm sure they have febrile illness on and off, and they must have taken some kind of drug and developed jaundice in the past. So at 10 years of age and directly presenting in hepatic encephalopathy, it's quite rare with
Yeah, it's
G6PD deficiency. In my practice, probably northern region, I've seen more, Rajiv sir, coming back to your question, I've seen more of autoimmune hepatitis and primary sclerosing cholangitis because they overlap a lot with acute viral hepatitis. So sometimes what happens, you have been treating an acute viral hepatitis and the child keep coming back even after 2 months, that the serum bilirubin levels are not falling. And how we are fooled upon that the hepatitis A IgM is always positive in those cases because obviously they are autoimmune in etiology. And eventually when you work them up for autoimmune profile, they come out because it's not just, you may not get one of the, AN might be positive, you won't get an asthma or LKM positive in that, but then you have to rely on CT as well as biopsy diagnosis to get a concluding diagnosis. So that is where I've seen more liver failures presenting with higher bilirubins, liver failure, and treated as acute viral hepatitis, but ultimately turned out to be autoimmune hepatitis.
So that's very true. And like general pediatricians like us, we don't even think of autoimmune hepatitis. So from this lecture, at least we should keep an eye open for an autoimmune hepatitis also. That's
Yeah,
very
so that
important.
is,
That's
if
important from the pediatrician, general pediatrician point of view, that we should keep this thing in mind also.
and another thing I'd like to add, we always get worried that the child, even after 2 months, is not having, the serum bilirubin levels are not falling. Because sometimes the parents keep coming back, the enzymes level have nearly returned to normal or are getting down. However, the bilirubin is going up in contrast. So early nutritional rehabilitation, and as Dr. Rakesh also pointed somewhere, that there is no role of restricted diet in hepatitis, in any kind of hepatitis. So nutritional rehabilitation is very, very important in these children.
True.
I would like to share a point from my own practice that, as Sangvi sir is saying, I would suggest that if we keep an eye on the albumin globulin and the SGOT-PT, we would hardly miss any autoimmune hepatitis. If you see a true AG reversal when there's a hypergamma globulinemia, even in a very mild, jaundiced case coming with mildly deranged transaminases, most probably we might be. It's AIH is not as uncommon as we presume. So please, as it's very disheartening to come across LFTs without protein, albumin, and globulin. And in fact, I have suggested at few meetings that if we should in fact include a PTINR always whenever there's even a bit of a derangement of LFT.
I think it's best whenever we are suspecting hepatitis, best to do a complete LFT with a GGT and a coagulation profile, just to be on the safer side. It might add on some, financial burden for the patient, probably a couple of hundreds, but it will give you a lot of result, especially, a rising INR, which is quite possible in acute viral hepatitis. And that's how they get worsened, because once they start bleeding, then it becomes difficult. And this INR, even if it is around 2.53, and if it is acute viral hepatitis, it can easily be controlled without any replacement therapy just by vitamin K.
True. So, Dr. Sufla, while you were just telling about GGT, Dr. Rawat has put up a question in chat box that role of GGT even I would like to ask you from your own experience that is GGT, I know in infants and cholestasis and less than like 1 year of age, GGT is of paramount importance. How important is it, and how does it contribute in sort of assigning the prognosis and etiology in children above, say, 2 years of age?
So my youngest, see, because we are sitting in a northern region where we see a lot of international patients also. So what happens whenever they are coming to a specialist, they've already been treated by primary pediatricians. So that's why GGT becomes very, very important, because we have to rule out cholestatic disorder, autoimmune disorder. Secondly, primary sclerosing cholangitis, I myself have seen a lot and treated as well. And they tend to deteriorate very quickly. If you don't pick them on time and start the treatment, they deteriorate very quickly. And their presentation is with high grade fever, rising CRP. So they have a very mix of presentation. They may not have a very high bilirubin, but they will have high liver enzymes and higher GTT because there is cholangitis. So that's why I always make it a point, infant or older child, I always order. In fact, in our hospital setup, GGT is not a part of LFT, but I always prefer. Even in acute viral hepatitis, sometimes they have more element of cholestasis, so they come back with bad pruritus and itching. So that you can give symptomatically also for some time if the GGT is high, but if the GGT is normal, then there is no role of URSO also.
Great, great.
So
Much
Rakesh,
appreciated.
There are
for the
two more questions which are left in the chat box. One is
about
by
the
Rama sir. How do you manage severe itching in acute viral hepatitis? Again, cholestasis is again one of the atypical manifestation of acute viral hepatitis. So the drug of choice to start with is ursodeoxycholic acid. To mention, ursodeoxycholic acid is to be used only in cholestatic phase of acute viral hepatitis. UDCA is not the drug for treatment of acute viral hepatitis. Most of the time we see in OPD prescription, UDCA is started even with bilirubin of 4, 5, 6, 7. So that is not the actually seen. So we start with UDCA. If the child is not responding to UDCA, we can add cholestyramine, which is a bile acid sequestrant. And some guidelines suggest there may be a role of steroid also. But before going to steroid, we should be sure that we are dealing with the acute viral hepatitis only. It is not the sclerosing cholangitis or autoimmune hepatitis or some other cause of viral this cholestasis, because this is also a typical manifestation of AVH. But whenever we have cholestasis, we should think of the alternative diagnosis also before starting steroids. Then mannitol, okay, हो गया. Role of Lola, Dr. Dilip has asked the role of Lola. So L-ornithine, L-asparginase, as of today, there is no role of LOLA in acute viral hepatitis or acute liver failure. Whatever the role of L-ornithine and L-asparginase is in the chronic hepatic encephalopathy, that too IV, not oral. So all oral Lola preparation are just marketing gimmick. They are of no use. You feel good writing them, but they do not do anything to the patient.
I would like to add emphasize rather on what Sumit has said. There is no role of Lola, there is no role of sorbitol, there is no role of any herbal remedy also in acute viral hepatitis. It is just, I think, to,
Add to the list of drugs.
Yeah, so I think Dr. Rakesh also mentioned in his presentation somewhere.
Including slide, yeah.
So yeah, actually it should not be given also, and even if the parents insist, then it should not be given. There is no role at all.
There have been cases of aplastic anemia. Most of us must have read actually in reputed journals because of use of these herbal tonics and other cocktails in uncomplicated acute viral hepatitis. They eventually landed up with aplastic anemia. So we should be very cautious. And actually, we
Yes, yes.
should discourage. We should, of course, never use, but rather discourage, as Dr. Sufla was saying, the parental emphasis might be there, looking at the traditional remedies, but we should put our hands off it.
Adequate hydration, give a multivitamin, you can give a vitamin C anti-emetic. That's all is required in acute viral hepatitis, nothing else.
So my last question, can I ask?
Yes, sir, please.
To Dr. Gunjan, because Dr. Gunjan, are you there?
Yes, sir.
Yeah. I just wanted to ask you, because you have a very busy OPD in the SAMES. What is the incidence of hepatitis E and C in your practice?
So we see
Because as
E
the
in
general
old.
pediatricians, we don't get it done. So I just wanted to know what is the incidence in Indore basically, or in the nearby areas.
So E we see in older children, adolescents and above, but C is usually not very common here also. At SAMES, we have not seen, and the usual pattern that we are seeing in E also, that fever is persisting for a longer period, It doesn't go off easily.
Okay. So
My dear,
any subtle sign or any just investigation without viral markers? Can you just think of these two things? Hepatitis.
Tanvi sir,
Subtle.
hepatitis C never presents with acute hepatitis until unless proved otherwise. So we don't even include it in the workup of acute
Yes.
hepatitis.
Hepatitis C rarely, hardly ever presents with acute viral hepatitis.
Okay.
So yeah. And Dr. Ajit Devda is asking the role of Silimarin pretty much like Lola or other things. Silimarin has no documented role in management of either acute hepatitis or chronic hepatitis. As far as allopathy is concerned, no role as of now.
Absolutely.
Okay, one question from my side. I am observing here that we are getting hepatitis patients throughout the year now. Previously, we were looking on during the season only. So, is it this trend is all over the MP, or I am looking in observing in this area only?
So
Hepatitis patients throughout the year.
I would like to add nowadays, I think hepatitis and enteric we are seeing throughout the year, and it is
Throughout
just
the year.
because of the bad food eating habits of the children. Unclean, unhygienic food, and it is now happening throughout the year, which is very unfortunate.
Throughout
Just
the
for
year.
Rajiv sir, I would like to add for hepatitis E. Usually, in acute viral hepatitis, we don't do an hepatitis E antibody, but as Gunjan rightly pointed, if the bilirubin is not getting better, mild fever is persistent, and the child condition in terms of nausea, vomiting is not getting better, and you've done all baseline, your hepatitis HbS-Ag is negative, hepatitis A is negative, and LFT, there is no signs of chronicity. In terms of PT-INR is normal, albumin is normal. Do a hepatitis E level. Sometimes they do turn out, and I've seen a lot of hepatitis E positive in children as well.
Okay. Thank you. So,
And usually the course is more
Thank you.
indolent as
Coming
compared
to
to
the
hepatitis A.
Yeah, that's right.
Dr. Dr. Rajesh, to wind up the things.
Yes, sir. I think
Dr. Rajesh.
with your permission, we can conclude the session. Yes, sir. Can you hear me?
Yes, sir. Gupta sir, G sir.
Yes, sir. Coming to the end of the session, and we are very much happy to see much interactive session throughout last 1 hour. And I now hand over the mic to Dr. Dinesh Nakle for conclusion. Dr. Dinesh, please.
Yes, sir. Yes, sir. Yes, sir. So, first of all, on behalf of MPIAP, I would like sincere gratitude to our faculty, Dr. Rakesh sir, for a wonderful and excellent case-based scenario presentation. I also like to thank our expert, Dr. Sufla ma'am, Dr. Sumit, and Dr. Gunjan Kalam ma'am for their valuable inputs. I extend my heartfelt thanks to Dr. Ashish Pathak sir and IIT Ujjain for hosting this session. I also acknowledge our scientific committee, especially Dr. Rawat sir and Dr. Rajesh Gupta sir, who is the master of this session. I am also thankful to our MPIB team, especially Dr. Rajiv Sanghi sir, Dr. Rajesh Sikka sir as an EBCIP member, and special words for appreciation to all the participants who have joined the online CME. Thank you everyone for your valuable participation. Thank you so much.
Thank you very much. Good night.